Good morning. So I'm a primary care doc, just like Steve, and continue to see patients, but I've, for the last year, been working in the Office of Community Care, and as Neil is showing, that this intersection between care that we have to provide in the community for veterans and in-person care and telehealth creates an opportunity for lots of sort of handoffs to take place. I'm going to go forward here. So I'm just going to start off by level setting with you about sort of three of issues that we have to address in VA. So one of them Neil's telehealth addresses is the fact that over 30% of our veterans live in rural America. Right? So rural health care is a challenge in general, and especially if you're supposed to be getting that health care in VA medical centers. Right? And although we may have around 1,200 around the country, and in our territories we don't address specialty care everywhere, and that's why telehealth is such an important answer to some of this, right? But it's not the answer because we still need procedures and other things that they can't answer. That's an issue we have. The other issue I want to just talk about is that our veterans tend to be a unique population. You know, Jeff talked about sort of underserved populations. Remember, veterans, average age about 67, 68, Vietnam-era veterans, they tend to have 2 more medical conditions and 1 more mental health condition than age-matched non-veterans. They also tend to make less money. They have fewer social supports, right? This is a unique population that we have to take care of, and it's a little more challenging. So when we try to coordinate that care, it's a population that we really have to be very thoughtful about doing that work. The other issue I'm going to mention is the fact that we do have about 170 medical centers, but a lot of points of care. And all of those, even though we have the same policies, they like to operate differently. They may be organized differently. We may not have clear systems to ensure that they actually follow our sort of policies and directions, and we all create our workarounds because healthcare, as everybody knows, is local, right? And we have our local markets, and we have local ways of doing things. So that's a challenge when the secretary will say, what's going on down in Shreveport? Do we have the visibility there as we do in Puerto Rico and Guam, et cetera? It's a challenge that we have. So one of the things that we're trying to do to try and address some of these issues is enhance and transform the way that we actually buy care in the community. And that's sort of my main sort of focus and issue that I've been doing for the past year since joining VA Central Office. What I'm just showing you here is this picture of our integrated health network here to the right. Right? So you have our medical centers in the center. Within them, there are local offices of community care that have several things that they have to do, and those are off to the left of the slide. They have to manage the consults. People like Neil and Steve who say, oh, I have a veteran who needs care in the community. They have to communicate that to somebody to try and coordinate and manage. That's in that local office. We have to actually create referrals to go out to the community. We have to decide what we're going to buy for this episode of care. It has to be coordinated in some way. Can we identify high-risk versus low-risk veterans who may need more, some may need more support in coordinating that care and some less? We have to figure that out. We have to find folks to work with in the community, and we have to make sure that we do good customer service, and then we actually pay the folks in the community. Another way to look at that is our Pentagon, which says that we have to start off with identifying who's eligible for community care. Not everybody gets to go to the community at any time for any reason, right? So we have to have eligibility. It needs to be clear for veterans, clear for staff, and clear for people in the community. We have to have standard ways of doing referrals and authorizations. We actually have to coordinate the care, and I'd like to do that in a standardized way where we can. And we have to have a network in red of how we buy that care. And we have to make sure those providers in that network get paid in a thoughtful way. And we have our dear friends who are our board of directors on the Hill who actually give us some direction of how we get to appropriate your tax dollars, right? And in doing so, there are laws regarding these things. So in order to actually have an integrated network, we have to have contracting ways of actually appropriating and obligating government funds. I can't have 500,000 individual contracts, even though I've got 500,000 different providers. Right? So we have to have big contracts with folks who have a network of providers, right? When we're buying care over a certain dollar amount. So we need to have standard ways in which we sort of do that. So when we look at trying to improve this, I came up with some foundational principles of how I want those local offices of community care to work, give them guidance, give them tools and technology to try and help them do this in a more standardized way so that we can hopefully improve the appropriateness, the timeliness, the quality of care that we can actually buy in the community when it is in fact necessary. We need to have clarity about who's supposed to do what when we're dealing with these handoffs. Can we build consistent processes, no matter whether I'm a veteran getting care in Boston, where Austin is, or I'm going down south to Florida in the wintertime. And if I need care in the community, I should be able to have an experience as a veteran that's similar if I get it in Boston or if I get it down in Orlando. We have to have active partnerships, not just with the folks around in our integrated network, but within our medical centers. I was talking to Steve this morning. He says, oh, I put a consult in for a veteran to go to the community. I'm trying to figure out what the status is, right? We have to make sure that we are working closely within the VA and coordinating care within the VA in addition to getting it outside of the VA. There's a lot of workarounds that people have created to try and figure out how to do that. And I need standard ways of coordinating the care. So I know that high-risk veterans are really going to get that entire episode of care and that someone's going to ensure that actually takes place because they get right back into the VA. And the folks need to have a way of understanding what happened out in the community so I can better care for that veteran thoughtfully and safely. So you probably can't read all this, but the bottom line is I've been in the VA. Well, I started as a medical student back in 1984, and then residency and chief residency at the VA in San Francisco. And then I left the VA for about 16 years, and I've been back for the last 12 now. And I've not seen, in my 12 years, and the ability for us to get IT solutions thought about and deployed to the field. There's 10 of them up here, and when we started 2 years ago, right, with these ideas that came from people in the medical centers who said, boy, it would be really great if we could. I wonder if this could happen, right? Well, within 2 years, we've got 5 of these deployed to the field already. 2 of them came from medical centers where chief health information officers had built their little workarounds to get information to their staff, and we heard about this, and we've been able to scale it nationally. Right? Nationally. And so we have had 5 of these deployed last year. Another 5 will be deployed starting in February to actually help with workflow, to help identify ways in which we can communicate clearly of the services that we are requesting in the VA to providers in the community through a standard portal. They will have visibility directly into the entire veteran's medical record for the duration of that episode of care. We will be able to have information coming back from them into this portal. Our staff will be able to still work in the portal, being able to make appointments, being able to message, right, in one system now. And we'll be able to have the ability to identify a directory. So if I'm a clerk and I've got a consult coming in from Dr. Finn for a cardiologist in the community, I'm a clerk, I can look up in my system the directory of a cardiologist or several cardiologists in my zip code. Right? Find that, talk to the veteran about the preference they have, schedule them in that same portal, right? So that we're creating systems that hopefully people will use because it makes it easy for them to do their work, right? So we're trying to get better. It's taking some time and diligence, and we still have a lot of questions. Are we going to decrease the hospitalizations and the ED visits by actually coordinating the care and doing this well? Are we not going to have medications being prescribed that we don't know about by this? Are we going to actually improve the quality and safety? So we have a lot of questions that we're trying to answer, and we have our colleagues like Austin over there and around the country who we're actually doing research with help us answer some of these questions as we move forward. Thank you.